Yeah.
Thank you for joining us and welcome to the Dignity Health Colorectal Cancer Case Review with Dr. Lorenc Malellari and special guest Angel Gentry. As with all Zooms, please stay muted for the presentation and ask your questions in chat. You can find the chat on your control bar at the bottom of the screen. Before we get started, we are hosting other educational events in the near future, beginning with a talk on kidney health by Dr. Edwin Youngstrom, March 17th at noon. And that will be followed by our Women's Below the Belt series with a talk on April 20th, and that's what's happening down there with Dr. Justin Lee. Also to watch out for and to be determined on the dates is May is Stroke Awareness Month, and May is also Skin Cancer and Melanoma Month. So please use the QR code to go to our eBrite and find more educational opportunities there. With that, I'd like to move on to what you are all here for today and introduce to you Dr. Lorenc Malellari, a colorectal surgeon with Dignity Health Medical Group, Bakersfield. Dr. Malellari graduated from Robert Wood Johnson Medical School in 2009 and completed his residency in general surgery at New York Medical College, Westchester Medical Center. He continued his fellowship on colon and rectal surgery at UC Irvine Health and is board certified in both general and colorectal surgery, wherein he practices advanced laparoscopic and robotic surgical procedures. Before turning it over to Dr. Malellari, I would also like to recognize and introduce our very special guest, Angel Gentry, who has graciously allowed us to share her story today. Thank you for being with us, Angel. Dr. Malellari, I turn it over to you.
Thank you, Patty. Let me take over the screen for a second.
There you go.
And here we go. And again, I also wanted to thank Ms. Gentry for sharing her story with us today. Here we go. So today we're going to be talking about colorectal cancer and how it's a very preventable and treatable disease. Hopefully, as we go through the presentation, everybody will have a better understanding of what colorectal cancer is, how much more common it is than most people realize, and why it's important to get a screen for it. March is Colorectal Cancer Awareness Month, which is why we're starting these events and educational projects in March. So a quick overview of the presentation. We'll talk a little bit about what colorectal cancer is, why should you care. I'll share some data and statistics about the United States. We'll bring in Mrs. Gentry to share some of her story going through this diagnosis and treatment. And then finally, we'll go over the symptoms that you should be looking for, what are the methods that we currently have available for screenings, and also a little bit of the surgical management of this disease, and what we have available here in Bakersfield for it, including the robotics surgical center that we have. So what is colorectal cancer? It is a cancer of the colon or the rectum, just like the name states. It usually starts as a polyp that grows inside of the colon. And with time, mutations will occur in that polyp, which will convert it to a cancerous polyp or cancer. Once cancer does develop, then it has the potential to spread to other parts of the body, including metastasis to other organs, like the liver or the lungs. Our goal is to identify these polyps or identify even the cancer before it has had the opportunity to spread to other organs or other parts of the body, and ideally before it hasn't even formed. So why should you care? Why are we here on a lunch break to talk about this cancer? Well, it is between the third and fourth most commonly diagnosed cancer in the United States, but it is the second leading cause of cancer-related deaths in the United States. More people die from colon cancer than die from breast cancer. More people die from colon cancer than die from prostate cancer. It affects both men and women, every racial and ethnic group. And the current statistics place the risk at about 4.5 to 5% lifetime risk of developing colorectal cancer, which means that 1 in about 23 men and 1 in 25 women will develop colorectal cancer in their lifetime. And the problem with this particular cancer is that it has very minimal and very nonspecific symptoms, especially early on. and is a life-changing diagnosis when cancer is identified. This is just a map of the world, just showing you the spread of colorectal cancer. The darker the shade, the more common the diagnosis of colorectal cancer is. And as you can see, it is somewhat more concentrated in the Western and developed world. As for the United States, we diagnose about 150,000 people with colorectal cancer every year, and about 52 to 53,000 of them will pass away from this disease every year, which means that currently we have close to 1.5 million people that live with this diagnosis of colorectal cancer. Either they're being treated for it or they're going through surveillance and monitoring. Yet it is a highly preventable, highly treatable disease, especially if caught early. An estimated 40,000 lives could be saved if we are able to screen all the patients that need to be screened on time. And these are just numbers, as you can see, the estimated new cases for 2021 and estimated deaths for 2021 as well. This is to show you a spread by gender on the left side and the different racial groups, and also spread by age on the right table. As you can see, the peak of the diagnosis of colorectal cancer is in the 60s with a median age at 67, but it affects almost all age groups actually. And if you look at mortality, on the left side, again, the spread by gender and racial groups. And on the right, you can see that that chart has shifted further out to the right because patients who are usually older will have a much more likelihood of diagnosis of cancer at a later stage and may not be able to tolerate the treatments for it. So the median age at death for this cancer is 72 years old. The reason why the screening matters and the reason why we're even doing this presentation again is if we can catch this cancer early, ideally before it is even formed, but even if cancer has developed, if we can catch it early when there's localized disease, early stage cancer, we are able to achieve a 90+ success rate in treating these patients. That is what the 5-year survival is on this graph is showing. So 90+% survival rate of 5 years for patients who have diagnosed with colorectal cancer early stage. Once the cancer cells spread to the regional lymph nodes and it becomes advanced stage, that survival rate drops. But look at the big drop that happens once distant disease has been identified, meaning the tumor cells have gone to other parts of the body or other organs. We want to prevent this from happening. We want to diagnose this cancer as early as possible so that we have a chance to treat those patients and obviously save their lives. 5-year survival, if you take every patient that's ever diagnosed with colorectal cancer, is about 64.7, about 65%. And as you can see on this graph, which gives you much more of a timeline, we're diagnosing colorectal cancer a lot less frequently than we did in the 1970s. That's the blue line up top. And part of the reason for that is because our screening methods and our screening rates have increased. So we're able to catch those polyps and remove them before they have a chance to turn into cancer. And as you can see, even mortality has dropped as well. And that has to do with the improvement in the treatment of this cancer, both medical treatment like chemotherapy, but also surgical treatment as well. There is some new information, however, that we're learned and we're seeing recently is that in a particular age group, colorectal cancer is actually increasing. This graph shows colorectal cancer rates in patients who are less than 50 years old. You can see the line, the blue line up top with the blue triangles. The rates was dropping up until the 90s, and then now we're seeing an increase in diagnosis of colorectal cancer in patients who are less than 50 years old. The reason why 50-year-old is a marker is because we used to recommend getting a screening colonoscopy at 50 years old. But we're catching more and more patients with diagnosis of colorectal cancer in patients who are younger than this age group, meaning that they would have been missed by the previous recommendations. Now, if you look at the mortality on this age group below, you can see that the mortality was dropping, but now it's starting to show signs of increasing, just like the incidence or the diagnosis rates show. And with that, I wanted to bring in Ms. Gentry, who's a colorectal cancer survivor. Ms. Gentry, welcome, and thank you for graciously sharing your story with us and our community. I'm
No
wondering,
problem. It's great to be here.
would you mind just introducing yourself, obviously, but also if you can share some of the initial symptoms that you're experiencing and kind of how this diagnosis was made with you?
Yeah, no problem. So I'm originally from Colorado. I moved out to Bakersfield in 2010 and work at Era Energy. I unfortunately got the diagnosis of valley fever back in 2016. And it took me about 2.5 years to get past the valley fever. And I was coming off of some of the medication associated with that. I had noticed some blood in my stool, and my first assumption was, oh, it must just be associated with that, change that my body was going through. And then over a few months, the frequency of the blood in the stool started to increase. And about, 4 months later, I had booked an appointment to go ahead and get a colonoscopy. And at the same time, while it was, a blessing and a curse, which you'll hear why in a bit, my husband and I decided we wanted to try and start a family. And going into that colonoscopy, they asked the infamous, could you be pregnant question? And, I said, well, we really only tried once, so it's pretty much impossible, but I guess, yes, there is a possibility. So I did get a blood test and confirm that I was pregnant, which delayed my colonoscopy for about a year. So going through that pregnancy, I did notice the blood starting to become more frequent. I had to kind of get through the delivery of our baby boy, and then also, get through some initial stages of breastfeeding. So I had enough milk saved up so I could go through the procedure about a year later. So after that year had elapsed, I did get that diagnosis at the second colonoscopy event that I was told that I had colon cancer.
That's pretty terrible news to get, especially when I guess you get, you go through all that difficulty management with a valley fever, and then obviously new pregnancy. It must have been quite a terrible, and difficult news to even digest or wrap your head around. Especially, and I think this was also important to mention, is that you were very young at the time.
Yes. Yeah. In my early 30s. So for me, it was a complete shock, one of those things that you think you're invincible. I came from an athletic background. I've always been very conscious about eating healthy and exercise, and to kind of be told that this was a reality for me, it was one of those things you can't even believe it really at the time. That I think I might have came up with a million different reasons why the doctors could have been wrong that first 24 hours after I was told. So
yes, absolutely. Yeah. And thank you for sharing that as well. And you obviously went through treatment, and you currently recovered through most of that. I would share also that you're in remission basically, and you're on surveillance, but there's no evidence of cancer left over, which is great. But if you don't mind sharing some of the kind of not necessarily the treatment modalities, but kind of how you went through the treatment process, and kind of how are you feeling now, really, after all this?
Yeah. So, I mean.
Oh, I think you got muted, Angie. Sorry. Let's see.
Oh, can you hear me?
Yep, I can hear you. Go ahead.
All come in at the same time. So this really was one thing, that was relatively, in the grand scheme of things, fairly easy to get through. And so while I reflect on that, if I had got the diagnosis earlier and it was able to stop after that, how much, grief and sadness and just basically really hard work that we had to get through as a family through chemotherapy, if that could have all been avoided, that would have been such a blessing. While that wasn't my case, going through chemotherapy, I think it was probably, I felt like it impacted me even more than I was being described. The treatment program typically impacts folks. I had a hard time. And, some of the longer term effects like the neuropathy and whatnot that I continue to deal with, really challenged me from a mind perspective, right, of mentally staying positive, and balancing kind of, what's easier from a physical perspective and getting through some of that stuff, but mentally making sure I'm here and positive and looking out for a good future for my family. So that's kind of my journey that I've had to go through, and something I continue to have to struggle with.
Sure, and I'm sure with a new baby that was much more difficult as well.
Yes.
And finally, if you have any messages or any comments that you'd like to share about your experience with this diagnosis, unfortunate diagnosis, and going through it.
Yeah, I think, for me, I could empathize with people. There's probably many reasons why someone might want to avoid a colonoscopy, whether it's just fear of the procedure itself, or fear of the prep, or is it a pride thing that you don't want to tell your family members or get yourself into a doctor and have to describe what you're going through or things you're noticing happening with your body. But really, time is of the essence, and I think we all owe it to ourselves to be proactive and try and get past some of those roadblocks that you might be experiencing if you're in a similar boat, just from the perspective of all of the, hardships that it will cause your family if you have to go past that surgery step into chemotherapy, potentially radiation type of treatment. It'll be worth it. So I can promise you it'll be worth it to go ahead and make that next step, get the colonoscopy done, and continue down your treatment path as planned.
Thank you very much. And again, thanks again for sharing your story and joining us today. Appreciate it.
No problem.
And we're all very happy to hear that you're doing so well. All right. So as Mrs. Gentry shared, she was in her earlier 30s when her diagnosis was made. And this is basically the news that we're gleaning from a lot of the statistics and numbers. But this statistics and numbers, they basically cover for real patients, real families, real people that are going through this. And I'm sure everyone heard about the actor that played the Black Panther, Chadwick Boseman. He died last year of colon cancer. He was 43 years old at the time. So the Never Too Young campaign that the Colorectal Cancer Alliance started was because of these numbers. Just to give you guys an idea of what we're really dealing with, instead of just looking at the graphs, is that in the 1990s, only about 6% of colorectal cancers were being diagnosed in patients who were less than 50 years old. Hence the screening rates the screening age was set at 50 because you would catch more than 90% of the patients that would have it. By 2020, about 12% of new colorectal cancer diagnoses are happening in patients who are less than 50 years old. And we're seeing an average of about 2% increase in these diagnoses every year. So much so that we expect that by 2030, which is not that long ago now, by 2030, the colorectal cancer diagnosis is going to be the leading cause of cancer-related deaths in patients between 20 and 50 years old. That is a huge increase, and it's a big problem that we're trying to address. So this, going back to some of the numbers and the statistics, you can see on the slides that if you look at the patients who are less than 50 years old with the diagnosis, it affects both men and women. The increase we're seeing in everyone. And if you look at the mortality rates on the right, you can see the increase is also happening in both men and women. So why is this occurring? Actually, before we go to that, you can see even if you look at different age groups, we're actually seeing that the increase in colorectal cancers in patients who are less than 50 years old is occurring more commonly in the white population. But the other ethnic groups have much higher rates of colorectal cancer as well. Now, why is this occurring? This graph just shows you the incidence of colorectal cancers in patients who are 20 to 50 years old in the United States, and this is in between year 2001 to 2005. As time passes, I'm going to move through the slides here. You can see that the rates of colorectal cancer increasing. The bluer the color, the lower the rates. The redder the color, the higher the incidence rates. Now you're looking at 2011 to 2015 here. Big difference. If you look at mortality rates in the United States, 1996 to 2000, you can see the slide over here. Now going to 2005, 2010, and 2015. These rates are increasing throughout the whole United States, but there's a couple of regions, especially the southeastern region and the southern United States, who has much higher rates, already had them from the beginning, but those rates have increased significantly in this group as well. And there are certain factors that we know are associated with colorectal cancer. Obesity is one of them. And if you can look at the obesity rates in the United States, both men and women has been increasing over time, and they're actually concentrated in the same region where we're diagnosing colorectal cancer much more commonly than we did before. This graph is showing rates of consumption of fruits, and mainly more than one fruit per day. And you can see the darker regions who consume less than that or have lower rates of population consuming more fruits also matches up with an increase in colorectal cancer diagnosis. Same thing with vegetables. And if you look at leisure activities or physical activity in general, the same group of states or regions in the United States that has lower physical activity rates has the higher increase or the increase in colorectal cancer incidence and mortality. Because of what I just mentioned above, the U.S. Preventive Services Task Force changed the screening recommendations for colorectal cancer. Currently, recommendations are to get started on your colonoscopy screenings at 45 years old. That means even if you don't have any symptoms, if you don't have any family history or any risk factors, you should get screened for colorectal cancer at 45 years old, not at 50 anymore. Because we want to catch patients who are going to develop this cancer, hopefully before they develop it, but at as early stage as possible. And there's a lot of different surgical and medical societies who spend a lot of time and effort to set up the screening guidelines recommendations. But basically, the difference between the, kind of which category you fall is between average risk and high risk. Average risk means no risk factors, no family history, no medical history that may increase your risk of colorectal cancer, and high risk are everybody else, basically. So who should get screened? The current recommendations are for every man and women starting at 45 years old to 75 years old. And the reason why the 75 years old cutoff is there is because the length of the life expectancy in the United States varies between men and women, but it's in the 75 to 80, depending on the year that you check it. So above 75 years old, the recommendations are to be individualized. Above 85 years old, the recommendations are to stop. I put an asterisk in there because depending on your individual health and how active and how how healthy in general you are, you may want to consider continuing your screenings to prevent the cancer from developing. Higher risk patients will obviously have different recommendations because of the family history or previous diagnosis. Going back to the differences in ethnic groups, the Alaska Natives and American Indians have the highest incidence of both diagnosis of colorectal cancer, but also mortality in North America and the United States. And again, the new findings with the younger patients that I mentioned earlier. And with racial disparities, African Americans have the highest rates of colorectal cancers deaths that we know of, and their rates are almost 40% higher than in whites. This is changing a little bit because of the increase that we're seeing on patients who are less than 50 years old being diagnosed with colorectal cancer more in the white population over the past 20-some years. So colorectal cancer is a very silent disease, unfortunately. I listed here on the left side of the screen some of the type of symptoms or warning signs that are associated with it. But as you can tell, they're fairly non-specific. Not only that, but they're very easily basically attributed to different reasons. So blood in and around the stool, most patients or most people really will have this occur at some point in their life. And if they tell their physician or they tell their family members or their friends, they usually say, oh, it's just hemorrhoids, or maybe you just got constipated, that's probably why the bleeding happened. Changes in bowel habits, developing diarrhea, constipation, sensation of not being able to empty your bowels, changes in the caliber of the stool, crampy or bloating of the abdomen, weakness, fatigue. I mean, I don't know of any person who has not experienced any of the symptoms, basically. That does not mean that the reason why you're experiencing the symptoms is a diagnosis of colorectal cancer, but that is one of the important diagnoses that has to be ruled out. And that is why when these symptoms do present themselves, and especially if they persist, it's important to check with your doctor about getting your colorectal cancer screenings, or at least have a conversation on whether that might be the reason. And the one that's a little bit more specific to cancer in general, not necessarily just colorectal cancer, is unintended weight loss. You shouldn't be losing weight if you're not trying to lose weight unless there's a reason for it. And that should really be investigated further. So who can get this disease? Unfortunately, everyone. There's certain risk factors that you can control. Things that, as I mentioned on some of the maps I showed you earlier, physical inactivity, obesity, smoking, heavy alcohol use, and obviously diet are important factors that you have control over to reduce your risk of developing colorectal cancer. But there's some risk factors, unfortunately, none of us has control over, including age. As we get older, our risk of developing colorectal cancer does increase. Family history, you can't pick, what family you're born with or what genetics you're born with. Having a diagnosis of inflammatory bowel disease, things like Crohn's disease or ulcerative colitis, does increase your risk of developing colorectal cancer. This is not the same as irritable bowel disease. Irritable bowel disease does not increase your risk of developing colorectal cancer. And also having diseases like diabetes, which is not controlled diabetes. And as I mentioned earlier about the certain racial and ethnic groups who have a much higher incidence and a diagnosis of colorectal cancer. The best thing you can do for yourself and your family members is make sure you get screened, and you push them to get screened as well. This slide just shows you the current screening rates in the United States. The darker, the redder the color, the lower the rates are. The bluer the color, the higher the rates are. The current average, if you put all the states together, the average screening rate for the United States is about 75%. And this is for those patients who need to get screened, not for the whole population of the United States. That basically tells us that about 1 in 3 patients who does need to be screened in the United States currently is not up to date on their screenings. And that's a problem. So talking about screenings, we're going to focus mostly on the average risk group, but there's multiple modalities that we currently have available. Colonoscopy, as Mrs. Gentry mentioned, that she had, is the gold standard for diagnosis of colorectal cancer, but it is also a treatment modality because it's able to remove polyps when they're identified. FOBT stands for fecal occult blood test, which is basically a stool test. This one is done annually. A FIT test, which is also a stool test, is also done annually. FIT DNA, which the commercial name is Cologuard. If you have seen those commercials that they have, this is also a stool test. And recommendations for that test are to be done at least every 1 to 3 years. FlexSig is basically a partial colonoscopy, evaluates the most common location where colorectal cancers are diagnosed, but it's not a complete colonoscopy, which is why recommendations are to do it more frequently. CT colonography is what's known as virtual colonography, and that test is also recommended to be done every 5 years. And a double contrast barrier is another radiological test that allows us to take a look inside the colon and identify polyps and masses. So the type of test, just kind of make it a little bit more easy to remember, there's basically 3 types: stool tests, endoscopic tests, and radiological tests. And that's split by, the categories on the slide over here. But I wanted to emphasize the fact that colonoscopy is really the gold standard for diagnosis and management of colorectal cancers and polyps. And this is what colonoscopy basically is. You can see on the picture on the left side, that's basically the average colon in most patients. No one obviously has the same length and the same makeup, but approximately. A colonoscope is a camera on a stick that is flexible. That stick or that scope is controlled by the physician, as you can see on the little picture up top, and is maneuvered through the little turns and kinks and angles of the colon in order to reach the whole lumen of the colon and evaluate the area on the inside. And as you can see here on the right, There's light at the tip of that scope and a camera, which is high definition camera. And the inner lining of the colon is examined all the way to the bottom, and any polyps or masses identified are removed or biopsied. So this is basically what you would see in a colonoscopy. You can see up top here, this is inside of the colon. You can see a normal lining of the colon, and there's this polyp over here. There's another polyp, different types, shapes, and colors, unfortunately. But that's the point of the colonoscopy, is to identify this. And as I mentioned earlier, it's not that you're just looking at it, taking a picture, and then coming out, but you can actually treat it. So we can put instruments through the colonoscope, as you can see on this picture here. So there's a camera, there's a light, and there's another lumen that we can place instruments. So in this particular case, for example, if we find a polyp, we can put wires and instruments inside of it to remove the polyp. And we don't just cut it and leave it, we actually retrieve this polyp and send it to the pathologist, where they'll be able to look at those cells under the microscope and tell us whether those cells have any tumor cells in them, or whether they are just polyp that hasn't had a chance to turn into cancer. The goal of screening, and the point of really this presentation as well, is to identify these polyps and remove them, and not give you a diagnosis of colorectal cancer, basically prevent it. Unfortunately, we can't prevent all of this, especially when there's a lot of people who are not up to date on the screening rates, and that is when surgery comes into play. Surgery is kind of like real estate. So location, location, location. Where the cancer is in the colon or the rectum will determine what surgery you're going to need to receive and kind of what to expect afterwards, basically. So timing, again, matters. If you can catch it early, you can remove it with a colonoscope and hopefully prevent surgery or not need the surgery. If it's advanced or unable to be removed, usually require further treatment like chemotherapy, sometimes even radiation with surgery. So this picture, just to give you guys an idea of what that means in terms of removing the cancer. So if the cancer is located in the left side of the colon over here, as demonstrated by the little blue dot, the pieces of the colon above and below the area are cut or separated, and the rest of the colon is put back together. If it's in a different location, a different part of the colon has to be removed and the other ends back together. So it's basically like plumbing. So you have a leaky pipe somewhere, you have to remove that leaky pipe and then put the other ends back together. The only problem is that in surgery, we don't have a Home Depot to get more piping. You can only use the stuff that you already have in you, which is why these techniques are being used for that. We do have some improvement and advancement in surgery, going from an open surgery to laparoscopic surgery, and the latest and most advanced methods that we have in surgery called Da Vinci or robotic surgery. You can see on the pictures over there the different surgical technique, but basically open surgery, if you or anyone that you know of has had any kind of open surgery, most people will be familiar with this type of incision. This is the belly button in the middle here. You can see all those surgical staples on top and a fairly big incision. And part of the reason for that is because you have to, as a surgeon, you have to put in instruments in your hands inside of the belly to actually remove the piece of the colon that has the cancer and put things back together. And, my hand is, it's not small, so I need a hole big enough to put my hand in there. So that incision is needed in order to be able to do the surgery. With MIS, or minimally invasive surgery, which includes both laparoscopic and robotic surgery, the incisions are much smaller. And the reason for that is because I'm not using my hand to go inside of the belly to perform the surgery, but I'm using small instruments that will allow me to perform the surgery without having to make those big incisions. I still have control of those instruments myself. The robotic platform or laparoscopic platform does not perform the surgery, but it allows to get my massive hand here inside of the belly through a very small hole and perform the surgery that needs to be performed. And you can see this on the side here. These patients have colon surgery with very small incisions on the top and the picture on the bottom as well. And this is what a robotic OR would look like. The patient will be sitting on a table with an assistant on the side controlling or helping the surgeon move the instruments around. And the surgeon will be sitting on the console here, controlling every aspect of the robot, both the arms, the camera, how the arms move, whether the arms move, etc. And to give you guys an idea of what the difference in size is, this is a dime. And you can see the size of the instruments that are available for the surgeon to use inside of the patient. And the good thing, or really the advancement that the robot brought to our surgical technique, is that this robotic arm at the tip has the same, actually more maneuverability than the human wrist. So just like I'll be twisting my wrist or rotating my fingers and my hand inside of the patient's abdomen to perform the surgery, the robotic instrument allows me to do the same thing, which much more smaller and miniature instruments. And basically, this is what the surgeon will be looking at. So when you put your face in the console, you get a three-dimensional view of the patient's abdomen, and you use this arm controls basically to actually move the robotic arms and perform the surgery. And this is a patient of mine that had robotic surgery for colon cancer. You can see in the operating room here on the right, I'm sorry, on the left side of the screen, at the end of the procedure here in the middle, and then 2 weeks later on the right. You can see those smaller incisions do improve recovery time from surgery. And obviously there's some cosmesis benefits in terms of the size of the scars and the location of the scars. Further advancement that we have in surgery right now, including robotic surgery, it also includes things like intracorporeal anastomosis, transrectal or transvaginal extractions, meaning that we avoid this incision over here because we do still need to get that tissue or the specimen out of the belly in order to send it to the pathologist. But with robotic surgery, we can control where that incision is made. With open surgery, we cannot. These new advancements allow us to, in certain cases, to avoid that incision completely as well. And with the robotics surgery, we do have available here in Bakersfield. We actually have a robotic surgical center right here at Mercy Hospital called the SA Camp Company's Robotic Surgical Center. And that's been going on for a few years now and has already been recognized by SRC as a center of excellence in robotic surgery, minimally invasive surgery, and also colorectal surgery. And we have a number of surgeons who have also been recognized as surgeons of excellence in robotic surgery here in Bakersfield. And you can see here some of my colleagues who perform robotic surgery and are helping our community and our patients going through a very difficult time. So going back to colorectal cancers, what are some of the steps that you can take to lower your risk of colorectal cancer? So get screened, get your regular screenings done, especially if you have no symptoms or no risk factors. Get started at 45 years old. If you have family history, if you have any personal history, or if you have any of the other risk factors that increase your risk of colorectal cancer, you need to get started sooner. Eat plenty of fiber. Between 20 to 35 grams of fiber a day are the current recommendations in the diet. And that's difficult to achieve with most, unfortunately, of the diet that we have. But basically, you'll be able to increase your fiber intake by increasing the amount and frequency of fruits, vegetables, and whole grain breads and cereals that you can introduce or add to your diet. Eat a low-fat diet. That improves your rate of developing, obviously, other medical issues as well, but also decreases the risk of developing colorectal cancer, polyps, and cancer. Foods that are high in folate, and you find this in leafy green vegetables. And again, the alcohol and the smoking, excessive use of both has been shown to be independent risk factor of developing colorectal polyps and cancer. Exercise, I mentioned that before when I was talking to you guys about the areas of the United States that have a higher risk of colorectal cancer. The current recommendations for exercise and activity are about 20 minutes, 3 to 4 times a week. Now, this does not mean that you have to go running for 20 minutes, 3 to 4 times a week. Any kind of physical activity has been shown to be beneficial. Even walking, jogging, gardening, if you enjoy that, will improve your health, but also reduce your risk of developing colorectal cancer. And this is kind of putting it in a nice little package here. So limit alcohol intake, don't smoke. If you do smoke, try to stop. Increase your fiber intake, whether by changing or improving your diet or taking fiber supplementation. exercise regularly or at least be active, depending on your usual daily life, whether you're working, in a desk and you're kind of stuck sitting for most of your day. Plan to perform at least some activities, whether it's several times a week or on the weekend, to keep your body moving. Get your regular screenings done. Especially be aware of risk factors that may increase your incidence of or your risk, of colorectal cancer. So be aware of your family's history, if possible, medical history, to make sure that you're up to date on it. And reduce, as far as the diet is concerned, reducing meat and meat products, processed food, saturated fats will just help your overall health, but specifically for colorectal cancer will decrease your risk of developing polyps and also cancer as well. And a healthy body weight, and that goes with the obesity that we mentioned earlier. So hopefully some of this slides and information is answering your questions about colorectal cancer, how important it is, how common really it is, and how important it is to stay up to date with your screenings. And going back to the beginning of the slide, this is a very preventable and treatable disease. We just need to get enough patients to get screened for it so we can catch it and hopefully prevent it. But even if it does develop, catch it as soon as possible, which will allow us to give you the best chance to beat it, basically. Thank you very much. And that was the talk for colorectal cancer. Let's see if I think there might be some questions.
Yes, I do have some questions here in the chat, Dr. Malellari. So let me go ahead and start with some of those. And very good questions, I might add. Thank you so much for the valuable content, and also to Angel. That was just really meaningful to hear it from a patient perspective and how you went through what you dealt with, and that it happens in such young people. So that's just very insightful, and we thank you so much for sharing. So with that, the first question I have here is, how accurate are the at-home tests? Are they any good?
Yes, so they're pretty decent. So let me go back here where we had the different tests. So as I mentioned, the colonoscopy is the gold standard. It's both a diagnostic and a treatment modality. The stool test, if you had to kind of put them in a list in terms of accuracy, the Cologuard is at the top. Below that is the FIT test. And the one that's the least sensitive and specific is the fecal occult blood test. There's a reason for that. The fecal occult blood test is only checking for something called hemoglobin, which is blood. Unfortunately, it's not able to differentiate between blood from you versus blood from something you ate, like if you had a steak, for example. The fecal immunochemical test, or FIT test, is specific to human blood, meaning that if you do have bleeding in your stool, that test will be positive, and the incidence of it being accurate is very good for that. Unfortunately, the problem with that test is that you can have bleeding for a million other reasons. So it's not very good at diagnosing colorectal cancers. Also, the other thing to remember is that in order for you to notice bleeding in your stool, or even for this test to be picking up the blood in your stool, the polyp, the mass, the cancer has to be quite big and quite advanced. The point of screening is to identify those polyps before they have a chance to turn into cancer. And small polyps and small masses sometimes will not bleed, so you would not have necessarily a positive test on this. The most accurate that we currently have, the Cologuard test, is actually checking for both the human hemoglobin or human blood in the stool, but it's also checking for something called strands of DNA in the stool that has been linked to mutations of colorectal cancer. And the reason why that works is because as the stool is passing through the lumen of the bowel where the mass is, it's kind of sloughing off cells from the tumor, and they're able to test and pick up those mutated DNA tests. So just to give you guys an idea, Cologuard test is about a 20+% rate of false negative and false positive. What that means is that about 20% of the time, the Cologuard test is negative, there's a possibility you may have a polyp or cancer in there. And about 20% of the time when the Cologuard is positive, it's a false positive, meaning that you don't actually have anything in there. The other thing that I wanted to make sure that I mentioned about this test is that if any of these tests, whether it's the stool test or the radiological tests, are abnormal, meaning that they report that there's something going on, the next step is actually a colonoscopy, because that was the only way to not just identify the problem, but also biopsy it. So you can actually get the tissue to the pathologist to confirm the presence of cancer or even remove it. So basically, you kind of fall back to the colonoscopy anyway. And because those tests are not, 100%, they have to be done much more frequently in order to be reliable.
Wonderful. Thank you so much for the insightful answer. On here also, I have another question. It says, what percent of people who must have chemotherapy, what's the percentage of people who have to have chemotherapy on top of surgery? And are there other treatments other than those two?
Yes. So I'm going to go back here to this slide. Let me see here. I'll show you what that means. So this is what basically it's staging. This is what tells us what is the best treatment for these patients. So the localized disease are patients who have stage 1 or stage 2 cancer. Those patients, the cancer cells have formed, they have the right mutations to be called the cancer, but they haven't had a chance to actually grow through the wall of the colon and reach the other side of the bowel or the other organs. If we're able to remove those cells, with surgery, that is the reason why this 90% survival rate is. Those patients in stage 1 and stage 2 cancer will usually require surgery only and no chemotherapy or radiation. Once it becomes regional, that means that the tumor cells have reached the local or the regional lymph nodes, meaning that they have achieved the ability to leave the area where they started. Then surgery alone in those patients is not enough. Those are patients who are basically stage 3 for colon cancer. In those patients, surgery is important and is probably one of the first treatment modalities, but then those patients will require chemotherapy. And the reason for that is because surgery is very localized treatment of the problem. Once the tumor cells start leaving that area and start floating into the lymphatics and the bloodstream, there's no way to see them or catch them or kill them, basically. So you need a treatment that can follow the blood vessels and the lymphatics and kill them where they are. And that is what chemotherapy is. Distant disease, which is the last one here, is when the cancer has not only left the area, but has actually established itself in a different organ, like the liver or the lung. Those patients are much harder to treat because those tumor cells have achieved mutations that make them fairly resistant to the chemotherapy agents that we have. And most patients will unfortunately succumb to this disease at some point. There's a number of different chemotherapy treatments that we have. Thankfully, the standard treatment works very well for most patients, but unfortunately not for everyone.
Thank you for that. And then also here I have, what is the preparation like for a colonoscopy? What can I expect?
That's a good question. I don't know if Mrs. Gentry is on. She can actually give you exactly what it is like.
Yes.
How important is it, right?
Yeah. So I guess I'll explain it. But basically, there's different modalities to clean the colon. As you can see on the picture, the scope has a camera right at the top. So if you're in, think of the colon like a tunnel. So if you're inside of the tunnel and the tunnel is full of stuff, you're not going to see whether there are things on the wall that are abnormal, polyps, masses, etc. So it has to be cleaned. And the way that we have now, the cleaning management or the cleaning protocols that we currently have are much better than they used to be. I think some of patients might have heard about cleaning, drinking like 3 gallons of liquid to clean the colon for a day before, and then, going to the colonoscopy procedure and then coming back home. Now we do have better agents in order to do that, which are much better tolerated by patients in terms of not getting a lot of cramping, a lot of abdominal, discomfort during the cleaning process. But at the end of the day, the colon has to be clean. If it's not cleaned, we're not going to be able to see inside of it to get that view and to get that diagnosis done. But we do have better agents now to clean the colon. What I use, I can tell you for my patients, for example, I give them a mixture of Gatorade fluid with Miralax and Dulcolax laxative pills. in preparation for the colonoscopy the day before colonoscopy. And most patients usually tolerate that very well, but there's other options as well if there's been issues in the past or someone is worried about their preparation.
And then one more question here that I thought was something that we kind of touched on, but maybe just to reiterate, is how much does family history increase the chances of colon cancer? And again, when are those times that you get checked prior to that 45 years of age for the screening age?
Right. So family history, it depends, unfortunately, because there are certain genetic mutations which will significantly increase your risk of colorectal cancer. And there's certain family history or medical history that can increase it somewhat. So for example, if you had a family member that has had the colonoscopy and they found polyps in them, if they were, if they develop or they're found, to have polyps, then your risk of developing polyps is also higher. If they were diagnosed with cancer, then your risk of developing colorectal cancer is much higher. So what we recommend for patients who have family history like this is to get screened at least 10 years prior to the diagnosis that was made on your family member. And it also matters if your family member is a close relative, meaning like a brother or sister or a parent, versus uncle, aunt, or second or third cousin and things like that. But there are some differences in the type of family history that increases your risk factor. So for those particular questions, I would recommend following up with your doctor and getting those answers to your specific situation.
Okay, and then I've had 2 requests on one other question, so I feel like it's definitely valuable to answer. So we had a question in regards to diverticulitis, and it's, if you've been diagnosed with diverticulitis, what type of diet should you follow?
Okay, so just to clarify, diverticulitis does not increase your risk of colorectal cancer. So I'm going to say that again, diverticulitis does not increase your risk of colorectal cancer. Diverticulitis is a significant and serious disease on its own, but thankfully, patients who have diverticulitis do not have a higher risk factor of developing colorectal cancer. As far as diet is concerned, is actually fairly similar to the diet that I mentioned here in terms of improving your diet and improving the quality of your stooling. My recommendations to patients who have a history of diverticulitis is to take fiber supplementation daily on top of their usual diet. Also to decrease or ideally eliminate things like red meats, that includes porks as well. And you don't have to be a vegan per se, but you want to minimize the amount and the frequency of time that you're introducing meats and meat products to your diet. So the actual diet changes or adjustments are fairly similar between the ones that will improve your risk of developing colorectal cancer and the ones for diverticulitis.
Thank you so much. Okay, with that, we are reaching our hour mark, so I'm going to go ahead and share my screen again so that we can wrap this up. There we go. From all of us at Dignity Health, we thank you so much again to our special guest for sharing your experience with us here today, as well as on the podcast. Thank you to Dr. Malellari, as always, for all you do to treat those facing this form of cancer and for being our physician champion to create much needed awareness. For our attendees, if you'd like to hear more about Angel's story, please find your way to our podcast. You can go to the Dignity Health's Hello Healthy page on your favorite podcast app, And for those of you who've registered online, be watching out for your screening kit. That concludes today's Spotlight on Colorectal Cancer. Thank you so much for joining us.
Thank you, Patty.
Thank you. Thank you, Doctor.